So I'm going to be talking about my favorite topic in the world, which is young adult and adolescent hip pain. Because despite all the joint replacement surgeons in this room right now, there are causes of hip pain that do not require joint replacement. All right? So just to introduce myself, my name is Erin Dawicki. I've been a physician assistant in pediatric orthopedics and sports medicine for over 15 years. I love working with kids because their stories are amazing. I ordered an MRI for a kid last week who said, "Oh, good, that's been on my bucket list." So the other thing on his bucket list was he wants to ride on an elevator, but on the top of the elevator, just to see what it feels like. I'm like, okay, next time you see me, I want the rest of the list. I gotta know. Kids have the best stories. So their ideas don't know the limits of physics or gravity. And sometimes when they meet up against those limits of physics and gravity, they get to meet me in the clinic and we help put them back together. So I worked at Boston Children's Hospital for the first half of my career on the young adult and adolescent hip team. So that's why this is my favorite topic, because I did a lot of clinical research in it. So we're going to talk about diagnostic pearls and pitfalls today. See if I can advance this. There we go. So who gets hip pain besides old people? So basically everybody. There's hip pain that presents in every stage of growth and development. This is a quick list. I'm not going to go through it because we're going to keep this on time. So common causes of young adult hip pain that I'm going to cover today are acetalber dysplasia, which is the leading cause of osteoarthritis in the hip and the leading cause of joint replacements. Femoral acetalber impingement, or FAI, psoas tendonitis, and iliotibial band syndrome, and trochanteric bursitis. So I love this image right here. This is a professional ballerina who did a split in an MRI because they wanted to see what the forces in the joint, what happened. And in most cases, when you're watching a professional ballerina put herself through these positions, the joint is actually subluxing. So you can see the hip actually dislocating on the MRI when they do this position. So a lot of the best gymnasts and contortionists and ballerinas, they have some element of either ligamentous laxity, instability, or hip dysplasia. So they get that abnormal range of motion that most of us can only dream of. So when somebody comes into my office and I'm worried about hip dysplasia, they usually come in presenting with pain on the side of their hip, and that's due to abductor fatigue. So mild hip dysplasia usually does not become symptomatic until they're older into adulthood, when they've started to develop damage in their hip. So when a child comes in or an adolescent comes in with lateral pain on the side of their hip, the first thing I think about is abductor insufficiency. So activity-related pain is my pearl for thinking, this might be hip dysplasia. So we start with images. I always get a standing AP radiograph of the pelvis with a beam centered on the femoral heads. And this is important because sometimes you can have a pseudodeficiency where there's a leg length discrepancy or there's other structural abnormality that's leading to this abductor fatigue that's not related to dysplasia. We always get a false profile view, which shows the anterior coverage of the hip. So sometimes if somebody has psoas insufficiency or psoas dysfunction, it's due to this anterior undercoverage. Once we've determined that they do have dysplasia that needs surgery, there's a special view called a von Rosen view, which simulates how much coverage they would get after doing joint preservation surgery. And there's a special MRI protocol that's used particularly in Boston to determine whether people are candidates for joint preservation surgery. It's called a degenerate MRI protocol, and you can actually measure the acetablar and femoral head cartilage to see whether or not somebody would get success and keep their joint for more than 5 years after a pelvic osteotomy. So these are the different angles that we look at on these x-rays to see whether or not a patient needs surgical treatment or is a candidate for non-operative treatment. This is what a periacetabral osteotomy looks like. So when somebody's ball, so the ball and socket joint is here, if the ball part is undercovered, you actually cut the bone all the way around the pelvis and rotate the pelvis over the ball so it's equal force distribution when the person is walking. So those screws are as long as they look. So if you go to Home Depot and get some decking screws, they're very similar to that. And at least at Boston Children's, we would allow the patients to keep them after surgery. And people would make cool things like wind chimes and Christmas ornaments, all sorts of stuff out of them. So next is femoral acetalber impingement, which is kind of an up-and-coming topic over the past 5 to 10 years. So patients typically will come in and complain of pain with sitting in one position for a period of time. They mention constantly shifting position to get comfortable and pain with going from sitting to standing. So the most common question I will ask a patient to really determine if they've got pain with sitting is, if I asked you to sit on an airplane and fly cross country, could you sit comfortably for the entire flight, or would you keep shifting to try and get comfortable? And most patients with hip impingement cannot sit for more than 30 minutes or so before they're shifting. They also complain of pinching in the groin in certain position. A lot of particularly male athletes will say, you know, I've just always been tight and I've always gotten these groin strains, and my coaches and people have tried to stretch me out for years and years, and I just can't loosen up. So if somebody's coming in with a history of long history of groin strains and just being tight in their hips, think about hip impingement. So imaging for hip impingement, pretty similar. So we still get that standing AP radiograph of the pelvis, so looking for leg length discrepancy. There's something called a sagging rope sign, which is overgrowth at the physis. So they've seen the adolescents, particularly who are active, they get this overgrowth sometimes at the growth plate. There's acetalber overcoverage. So this would be a lateral center edge angle of over 40. And that causes something called pincer impingement, which we're not going to get into the nitty gritty today. False profile will also show excessive anterior overcoverage. And then there's a special view that we get in our office called a modified Dunn lateral. So that's with the hips slightly abducted and internally rotated. It's been found to show the cam lesion better than just a straight frog lateral. So we do a measurement called an alpha angle, which needs to be greater than 60 for the insurance companies to approve any type of surgical. You can also see an impingement trough for pincer type impingement, which means that the cup is too deep, so the ball is pinching up against the cup in certain positions. So this is a picture showing a cam lesion. So that's a pretty big bump. So the physis, let's see if I can figure this out. So this physis goes over and down instead of going straight across. So treatment for FAI, just like everything else we've talked about in orthopedics today, we start with physical therapy as our first line treatment. Next, we like to try a diagnostic injection because sometimes intra-articular pain and extra-articular pain are hard to determine which one's which. Ideally, you don't do the diagnostic injection as part of the MRI because sometimes too much fluid is injected into the capsule and it kind of muddies the waters. So we have Brett Turan in our office who does these diagnostic injections for us, and he does a fantastic job. If the diagnostic injection is positive and all of their pain goes away, then we talk about doing a surgical debridement to remove that bump and address any deficiencies in the labrum. So the next one I see a lot, mostly in adolescents, is the snapping iliotibial band syndrome. So typically I'll get a teenage girl who's just had a big growth spurt in the past 2 years who will come in and say, hey, I can pop my hip out of the socket. And I'll say, okay, show me. So they get up there and they stand and they kind of wiggle to the side and you see pop, pop, pop. I'm like, well, your hip's not actually popping out of the socket because that would be an emergency. But then we talk about the iliotibial band and how it's snapping over the greater trochanter. Most of these resolve with physical therapy. In very few cases, you do a small surgery and you make a little cross-shape incision over the iliotibial band to lengthen it so it's no longer snapping. But we see this in a lot of forward plane athletes like marathon runners, cyclists, people who are all going in forward plane and are not doing a lot of lateral motion or cross training. Sometimes it's a sign of a structural abnormality like a leg length discrepancy. And then psoas tendonitis. So another common thing that we see in the office, especially in adolescents. So typically they will complain of pain going up the stairs. So I'll start by saying, do you have pain going up and down stairs? And they'll say yes. And then I say, well, do you have more pain going up the stairs or down the stairs? And psoas tendonitis is typically going up. So lifting that leg up and activating the anterior hip flexors. They'll also talk about difficulty getting out of the car because you're lifting and abducting your leg out of the car. And sometimes they'll mention actually using their arms to pick up their leg by the end of the day because they just can't lift it up on their own anymore. Sometimes they'll complain of a popping in the medial groin, but not always. And I do try and replicate the popping in the office, which they love. So again, physical therapy, first line. We have an amazing physical therapy department right in the house, and it's really convenient to communicate with them and talk about what our treatment plan is. Sometimes we'll have them go to our physiatrist for a diagnostic injection into the psoas bursa. And surgery is pretty rare for this. So either the lengthening of the IT band as previously discussed, or lengthening the psoas, or sometimes there's some capsular adhesions that you can release with arthroscopic surgery. So next we're going to talk about how I go through a physical exam to try and figure out which one's which. So in general, I just watch the patient. So oftentimes I'll be standing at the desk filling out paperwork and I'll see the next person come down the hall and it'll be one of my adolescent patients. I watch how they walk. Are they limping? Is their foot in external rotation? Next, I watch their sitting position. So impingers are always slouched and have really bad posture. And then as we're talking, I look to see if they can actually stay in one position for a period of time or if they're constantly shifting position. I then ask them to point to the location of their pain with one finger. I watch their stance, so I have them rise from a seated position. So I look to see if they're leaning in one way or pushing off of furniture. Do they look stiff and sore when they do so? I look at the level of their pelvis and their shoulders. So particularly in kids with undiagnosed scoliosis, you may see one shoulder level is higher than the other. Is their weight evenly distributed? And then I have them do a standing Trendelenburg test, which is supposed to be shown in a video. There we go. Perfect. And I look at their general alignment. This is an example of a standing Trendelenburg test. So in somebody who is positive with, their pelvis actually tilts. Next, we do a supine exam. We look for symmetry. So I always start by log rolling and I inter-rotate both legs at the same time. This is an example of internal and external rotation and extension. Next, I want to do straight flexion of the pelvis. Now, as soon as the contralateral pelvis starts to lift up off the table, that's the end. So we used to get residents who come in and say, wow, this patient's got 140 degrees of hip flexion. Most people don't have that because their pelvis actually starts to lift up off the table. So you got to watch that carefully. Internal rotation and flexion. So you'll find that this is limited in patients with impingement, skiffy, and Perthes. Patients will often guard as they anticipate discomfort in this position. And you'll get increased interrotation in patients with anteversion. So a quick, easy way to find out if somebody's anteverted or retroverted is ask them how they prefer to sit on the floor. If they like to sit in a W position, that means more anteversion. If they like to sit crisscross applesauce, that's more retroverted. So external rotation and flexion is painful in patients with psoas irritation, increased in patients with retroversion, and posterior pain may indicate trochanteric impingement, which is a rare, but people are recognizing it more frequently. This is an anterior apprehension test. So in patients with anterior undercoverage of their hip, they'll feel like their hip is about to pop out of the socket. So the patient needs to be on the edge of the table, the leg is extended and externally rotated. And sometimes they will grab or gasp or grab their hip audibly and say, oh my God, because they literally feel like it's gonna pop out. An anterior impingement test is flexion, adduction, and interrotation as positive for labral pathology. And provocative psoas maneuver, this is a demonstration of that. So it's flexion, abduction, external rotation, and extension. And oftentimes they'll feel a clunk as the psoas flips over the anterior capsule. Stinchfield test or a resisted straight leg raise. And kids with avulsion injuries will have pain with this, as well as a soft femoral head as seen in Perthes disease or avascular necrosis. And then abduction, just feeling the natural abduction across the table is a normal physical exam maneuver, and adduction as well. This is a Patrick's test or a figure of 4 position, and we typically measure the distance between the exam table and the patient's knee. And pain may be posterior due to SI joint pain, psoas impingement, depending on the pain and location. Finally, we palpate. So we palpate over the ASIS, which in skeletally immature patients may be painful, especially if there's an avulsion injury. And then we work our way down the iliotibial band and over the greater trochanter. Lateral exam, palpate the greater trochanter and test abductor strength. Now, all of you therapists know in here that patients will cheat with testing abductor function. So make sure the hip is fully extended before you have them abduct against resistance. And then this is a bicycle test. So the bicycle test for snapping of the iliotibial band over the troch and over Gertie's tubercle. So I put my hand typically over the knee and over the hip when I do this, and I feel for clunking or clicking or pain. Prone exam, prone internal and external rotation. And I ask patients questions while I'm doing this exam. If they're focusing on trying to answer your questions, it's harder to guard and it's harder to cheat when I'm doing these exam maneuvers. I always start on the asymptomatic side first, and then I put the hip through its arc of motion gently to feel for subtle catching, grinding, or mechanical symptoms. Many patients will have intra and extra-articular pain at the same time. So sometimes it's difficult to figure out if the pathology is mostly from inside the hip joint or outside, which is where diagnostic injections come into play. Radiographic abnormalities do not always require surgical intervention. Not all bumps are symptomatic. Dysplastics typically have better than average range of motion. However, with activity-related pain, that's where I typically refer them to possible surgical consult. And then my last pearl is that impingers, as we mentioned, cannot sit in one position for long periods of time. Now, my final plea is that all of us have the opportunity to catch a SCFE, which is a slipped capital femoral epiphysis, at any interaction with our pediatric patients. So if you see a kid who's kind of between the ages of 9 and 13 who comes in with pain in their thigh that they're saying is knee pain, please check the hip. This is a quick, easy one to get them on their back and flex and intra rotate. And if they have pain or limitations, send them our way and we'll take care of it. And these are my references. Thanks very much.